Hello, friends. So it's the end of the year, so I'll be giving this last talk of this year. So the talk is beta blockers in traumatic brain injury. So I'm sure, friends, I did a recently we had a Landicep trial where we spoke about beta blockers in sepsis. So the role of beta blockers in various conditions in ICU is evolving, and there seems to be positive signals in ICU, and we saw the trials with Landolol and Esmolol, and Landicep trial in subgroup analysis it did show benefit. Then there was a meta-analysis after that which really did not show, so on and so forth. So even in traumatic brain injury, so there are good signals with regards to beta blockers. So I only thought it's good to review this topic for all our trainees, and more so in neurocritical care and neuro patients. So you can keep in back of mind there is some value proposition in the use of beta blockers. So we look into the evidence. So there will be, of course, MCQ questions for all my beloved trainees at the end of the year. So I wish to acknowledge my colleague, Dr. Sanjay, who helped me develop this content. So just looking into what is the purported mechanisms as to how beta blockers can help. So if you look at a normal brain, so we understand when we say brain is normal, then there should be normal blood-brain barrier. So that's just a pictorial representation of blood-brain barrier. So there should be a normal blood-brain barrier. Because there is normal blood-brain barrier, the neuronal integrity is maintained and the nerve cells are functioning normally. So this is in normal situations. So when there is a traumatic brain injury, and I'm sure most of the listeners would know, there is something called primary injury and there's a secondary injury. And morbidity and mortality is dependent on both of these. So the primary injury is the injury that has happened due to the impact or due to whatever event. Secondary injury is what we put in all the efforts in ICU to mitigate the secondary insults, which I call it as 7 normals. They have to have normovolemia, normoxia, normocapnia, normotension, and normoosmolality, so on and so forth, and normothermia. So this is what we expect so that we prevent secondary insults. So when there is a primary injury in the brain, which is due to the acute insult, which can be a trauma or any other reason, so there are few changes that happen in the brain, and there are typically four sort of a changes that happen at the cellular level. So there is a necrosis because of the primary injury. There can be necrosis. There are micro hemorrhages that happen due to whatever impact. Then there is, because of these necrosis, hemorrhages, micro or macro hemorrhages, a lot of edema formation in the brain because we give osmotherapy for this. And there is inflammatory process. So these four sort of a variables that tend to happen after any primary injury, which is necrosis, edema, hemorrhage, and inflammation, leads to a vicious conundrum and cellular changes that leads to the brain dysfunction. That leads to ischemia and blood-brain barrier damage happens because of the perpetuation of these four events that tends to happen in the brain. So what happens in secondary injury? Again, in secondary brain damage, there is a blood-brain barrier damage and there is edema leading to hypoxemia. And this leads to ischemia. So basically, there is a lot of ischemic processes. So very often you would have seen in a trauma patients, initially they'll have a lot of hemorrhage, there'll be a lot of edema, but later on you would see a lot of ischemic areas. So these ischemic areas are perpetuated by this edema, hypoxemia, which leads to ischemia, and that leads to lot of influx of iron and calcium into the mitochondria, and there is mitochondrial dysfunction that tends to happen, and there is mitochondrial injury. So effectively, all these inflammatory changes, edema, and the hemorrhages, necrosis leads to effectively the cell damage, and this leads to release of lot of, there is some sort of a cytokine storm that happens within the brain, and there's release of, typically they have found these four variables which are tend to cause a lot of damage, which are caspase, kipines, and reactive oxygen species, and cystasin CYTC, and this leads to apoptosis, the cell death that tends to happen. So this is just a pictorial representation of the pathophysiological derangements that tends to happen following primary brain injury and secondary brain injury. And fairly, they're all intuitive for all our ICU trainings, but what eventually they all culminate into leading to the cell death by release of a lot of cytokines. If you recall that one, that's good enough. And what we see when there is a TBI or any brain insult is there is a descending inhibition that tends to happen, which gets inhibited. So there is a descending inhibition from the brain to the spinal areas, which does not happen when there is a TBI, and there is a activation of the sympathetic nervous system. So there is huge sympathetic surges that we tend to see, and beta blockers are purported to mitigate the sympathetic surges, which leads to multiple. Because as you know, the sympathetic nervous system is connected to every organ in the body, and multiple organ dysfunction can tend to happen because of huge sympathetic overactivity, because of impaired uh, sort of a descending inhibition that tends to happen because of the traumatic brain injury following either primary or secondary. So there is a sympathetic oversurge, and your whole utilization of beta blockers is to mitigate this sympathetic overactivity, which leads to organ dysfunction. So when you look at the sympathomimetic response in the TBI, so typically what they have is they have tachycardia, they have high temperature, then they have a hypertensive response, they have tachypnea, and they can have this decortication or deceleration or tonic posturing. So your whole intent of beta blockers is to reduce the catecholamine surge. So the whole intent is to reduce or mitigate your sympathetic overdrive, reduce the catecholamine surge, and prevent brain hypoxemia and reduce your secondary injury and maintain a balance between oxygen supply and delivery, because your whole oxygen delivery and supply balance gets impaired in traumatic brain injury, and our whole intent is to mitigate this sort of an imbalance that tends to occur. So this is the purported mechanism of beta blockers. And of course, traumatic brain injury, in addition to causing the effects on the brain by mitigating your sympathetic surges, it has other multimodal effects. It does reduce the catecholamine surge, and it does reduce the release of all these tumor necrosis factors, IL-1 beta and IL-6. And it has alpha and beta actions, as you know. And because of these activation of these receptors in TBI, there can be microthrombi formation and endothelial cellular leakages tend to happen. So and as you know, in polytrauma or traumatic, they have a surge response which leads to organ dysfunction. There is capillary leakage. And these are all sort of triggered by release of all these cytokines. And beta blockers are meant to mitigate this by causing blockade of alpha and beta, because alpha and beta activation leads to microthrombi and endothelial cell damage and leakage. All these can be mitigated by beta blockers. And obviously, this leads to microthrombi. So by activation of alpha receptors, typically there is a vasoconstriction, and this leads to increased pulmonary capillary pressure. This leads to pulmonary edema. All this is mitigated with the use of beta blockers. And beta activation, obviously there is cytokine release, and it can cause myocardial dysfunction also due to excessive beta activation. And this also is mitigated with the use of beta blocker, and this can lead to LV failure or cardiorespiratory dysfunction or cardioregulatory dysfunction. So all these aspects can be mitigated with the use of beta blockers, because alpha and beta activations are deleterious in traumatic brain injury. And traumatic brain injury can lead to a lot of sympathetic overactivity, can cause tachycardia, increased cardiac output, increase in oxygen delivery. All this can lead to coronary hypoperfusion. Beta blockers is meant to reduce the heart rate so that it reduces the oxygen consumption and increases the time for diastolic filling and improves the coronary perfusion. All this also has a multimodal effect in reducing the risk of cardiac ischemia also. So it has a multimodal effect which all can sort of be perpetuated by the traumatic injury. It is like a sepsis where there is a trauma in the brain and there is whole sympathetic activation, there is cytokine release that can lead to cardiac dysfunction, respiratory dysfunction, and microthrombi formation due to vascular integrity that gets deranged because of the alpha and beta activation. All this can be mitigated with the use of beta. This is the sort of a scientific plausibility of the benefit of the use of beta blockers in traumatic brain injury, which we spoke in sepsis also. So now we look into what are the studies. So now we know what is the science, what is the scientific plausibility of the benefit of beta blockers in traumatic, but we need to see whether it translates into the clinical studies. Are there any clinical studies? So there are good number of meta-analysis which are culmination of multiple trials. So we look into this. So this is a positive meta-analysis, beta blockers and traumatic brain injury, a systematic review meta-analysis which came in 2017 by the Canadian and US authors. So here they looked at 9 studies, and they looked at 8,245 traumatic brain injury patients. So 2,005 patients received beta blockers in this. This is a meta-analysis, and there were 6,240 in the control group. When they looked at hospital mortality, it was significantly less in the beta blocker group. As you see, odds ratio was 0.39 and confidence interval is statistically. So there was a mortality benefit in the meta-analysis of 9 studies. But in this particular meta-analysis, they did not look at the functional outcome, they did not look into the quality of life, and they did not look into the cardiorespiratory adverse events in this meta-analysis. But in most of these studies, the 9 studies, propranolol is the drug that they have studied in in traumatic brain injury because of its increased ability to penetrate your blood-brain barrier. So propranolol is more preferred, although other beta blockers also tend to enter blood-brain, but the increased sort of penetration is found to be in propranolol. So this is just a forest plot. As you see, all these are the studies which are from 2007 to 15, which showed a huge benefit with the beta blockers with the survival, and this was statistically significant. So this was another meta-analysis from China, because China produces a lot of meta-analysis. This came in 2021, the first one in 2017. So beta blockers for traumatic brain injury, systematic review and meta-analysis. Here they took 15 studies. The last meta-analysis took 12 studies. Here they took much larger, 15 studies, 12,721 patients. Here also they showed hospital mortality was significantly less with the usage of beta blocker, and that was statistically significant. Here they also looked at long-term functional outcomes, and even long-term functional outcomes was better in the beta blocker group, and that was also statistically significant. As you see, it was much better in the beta blocker with odds ratio of 1.75. And here they looked at cardiorespiratory adverse events, which was not looked in the previous meta-analysis. There was no difference between the beta blockers and a non-beta blocker group in this particular meta-analysis. So again, there are two meta-analyses you saw, one in 2017, one in 2021, both showing benefit with beta blockers with regards to mortality. The Chinese one showed benefit with even the functional outcomes. Then came 2023. This is the latest meta-analysis that again came by the US group, beta blockers in patients with severe traumatic brain injury, systematic review. Here they took 12 studies with 12,721 patients, where they looked at hospital mortality in beta blockers. Again, they showed it was significantly less with the beta blockers, albeit here it showed certain negative outcomes with other variables. They looked at duration of mechanical ventilation. Surprisingly, they found that the duration of mechanical ventilation was much longer in the beta blocker group as compared to the control group. And ICU length of stay also was much longer in the beta blocker as compared to the control group. And hospital length of stay also was much longer. So these were some of the negative aspects. Although mortality, there was benefit. So all 3 studies consistently showed mortality benefit. But this meta-analysis showed signals towards increased length of stay, increased duration of mechanical ventilation, increased hospital length of stay. So then this was another small study which came in UK. This is the latest, early intravenous beta blockade with esmolol in adults with severe traumatic. This was a feasibility trial. It was not a big trial. They just did this study, randomized control in only 16 patients. So they used esmolol, 10 micrograms per kg per minute. And every 30 minutes, they increased to 5 micrograms per kg per minute to reduce the heart rate by at least 20%. So by 15%. So the whole target was to reduce heart rate by 15%. And at the same time, to maintain cerebral perfusion pressure more than 60 millimeter. It was not a controlled, randomized controlled trial. They just took one arm and they did this study with esmolol in severe traumatic. Primary outcome was, this was a feasibility study. They wanted to see whether they can tolerate esmolol. So they looked at primary outcome as a maximum tolerable dose. Secondary outcome, they looked at mortality at 6 months, and only 16 patients, very small study, came in neurocritical care. So here they showed the mortality at 6 months was less, 12.5, but they didn't have a control group. But they compared with the standardized mortality rate for these patients, came down to 0.63, which means they felt that outcomes were much better, and they could show the mortality reduction by calculating the SMR at 12.5%, and they found it that it is a valuable tool, that beta blockers have some value proposition in reducing mortality at 6 months is what their conclusion was. So these are the studies that we have. So, so when you have to summarize, I think there is a scientific plausibility as to why we believe that beta blockers tend to have a protective effect on the brain by mitigating your sympathetic surges by sort of alpha and beta blockade. With the multimodal effects, it seems to have some ability to improve the outcomes. And meta-analysis shows strong signals towards mortality benefit Although the latest meta-analysis that came in 2023 shows there are signals towards increasing the length of stay or increasing duration of ventilation. So this is something to be kept in mind as a useful drug, which may add value in some of our traumatic brain injury. So we'll just move to the MCQs. So based on this, so I have 5 of my good trainees sitting here. So I'll be putting these MCQs, and which may be useful for all our listeners as well. So what is one of the primary mechanisms by which beta blockers may help in traumatic brain injury? So the options are reducing intracranial pressure, improving cerebral perfusion, decreasing the release of catecholamines, enhancing blood-brain barrier. Pragnya. Sorry? Loud. Okay, she says C. So C is the correct answer. Very good. So I request all my trainees to give a loud answer because I have my earphones. I can't hear you. Just tell the option. So which of the following beta blockers has been studied specifically for its neuroprotective effects in the context of traumatic brain injury? Yashaswini. Okay, B is the right answer, propranolol. So what potential benefit do beta blockers provide in the acute phase of traumatic brain injury? They prevent secondary brain injury. They promote rapid recovery of motor function. They reduce swelling of brain tissue. They enhance neurogenesis in the damaged areas. Swati. Okay, I think Swati says they prevent secondary brain injury. So that's the right answer. So good, well done. So in studies examining beta blockers in, this goes to Sanjay because Sanjay helped me develop this content. In studies examining beta blockers in traumatic brain injury, which has been observed regarding potential outcomes. Beta blockers have no impact on patient outcomes. This is a little confusing question. They consistently improve survival rates. They are associated with reduced post-traumatic stress symptoms. They worsen cognitive outcomes in severe cases. That's what I would thought. So one would immediately answer they consistently improve survival, but it is a meta-analysis, and meta-analysis we cannot take, although signals are towards, but there were deaths happened in both. But what was consistently seen is the C. They are associated with reduced post-traumatic stress symptoms was what was consistently seen in all the studies. Because meta-analysis showed both, but statistically it all appeared survival rates were better. But when you take studies, in studies, it was predominantly post-traumatic stress symptoms that were, so C is the correct answer. So this is a tricky question. So I asked Sanjay. So which of the following is a potential concern when using beta blockers in patients with traumatic brain injury? Increased risk of respiratory depression, hypotension and bradycardia, enhanced swelling in brain tissue, diminished neuroprotection. I, Jacob. Okay, correct. Type has given a fantastic answer. Hypertension and bradycardia is the side effects. So beta blockers are typically administered in traumatic brain injury in which phase of care? Only during surgical intervention, immediately during the emergency phase, in the chronic phase of rehabilitation, as a precautionary measure in all TBI. Dr. Pratibha. Sorry? D. Oh, she's given a wrong answer. Dr. Pratibha, I think it has to be given in the immediately during the emergency phase because that is where you have sympathetic surges. That is where you have cytokine storm. You need to give it in an acute phase. So B is the right answer. But I think our trainee, our colleague gave a D as an answer. So it is not a precautionary measure. It is to be given immediately during the emergency phase. B is the right answer. So last question to all of my good trainees here. Which of the following outcome is not typically associated with the use of beta blockers in the management of traumatic brain injury? Reduction in heart rate variability, decreased levels of anxiety-related symptoms, lower rates of post-concussion syndromes, improved cognitive performance in all patients. Which of the following outcome is not typically associated with use of beta blockers in the management of traumatic brain injury? First answer. Sorry? Are you all in concurrence with that? It doesn't lead to improved cognitive in all patients. See, any MCQ get where you said in all patients there'll be cognitive, that is going to be a wrong answer. So the D is the right answer. So thank you, friends. So hope the MCQs were good. It will be of value proposition. So invite all of you to submit valuable work to our Journal of Acute Care, which comes every 3 to 4 months. You can visit my website to rehear to this lecture. So I wish all my listeners a very fabulous and fantabulous new year. So wish you all the best, and we'll see you in 2025. Thank you. Thank you, one and all.